The webinar's live.
Okay, thank you very much. Welcome to the NHS Cheshire Clinical Commissioning Group Primary Care Commissioning Committee, which is a meeting that's held in public, although it's not a public meeting. And for those people that are attending, the only way that I can be alerted to the fact that you want to speak is through the chat box, which is on the right-hand side of your screen. So can you alert me if you want to speak? If I don't take any notice of it, will you just then sort of wave at me or shout, because I can't see all of you either. And what I'm going to ask is that you actually only use the chat box to alert me to the fact you want to speak. If you've got something to say, I'd prefer it if you say it, because it makes it far more difficult for me to keep tabs on what people are saying in the chat box and what people are saying actually on the link. So welcome to the meeting. We've got Denise Smith, who I know has had a few glitches to get in, but welcome, Denise. She's a new representative of practice managers on the committee, and it's her first meeting, so welcome, Denise. I've got apologies for absence from Paul, who I know though is here. I think Paul Bowen's here for some, and then Laura is also here to deputise for him. And I've also, yes, that's right. Sorry, Paul, thanks for that.
I just was going to say, I don't think Laura has the mandate to deputise, so she's simply observing, but I send my apologies because I have to go to the Cheshire East Leaders meeting, so apologies.
That's okay. And I also know that William Greenwood will be leaving us early as well, so so that's fine. I've got apologies from Annabelle London as well. I don't think I've got any other apologies that I've missed. If I have, then I'll make sure that they're recorded in the minutes. Okay. In terms of declarations of interest, has anybody got any declarations they want to make now? I know that as we go through the agenda, I'm going to raise this for every item because there are a number of areas where obviously our primary care colleagues are conflicted. So has anybody got any declarations of interest to declare now that are over and above those that they've made already? No, nothing in the chat.
Chair, I have.
Okay.
Oh, sorry, I have. Sorry.
You have?
Yeah, Middlewood Partnership, which I'm a partner is, has got a application for a rent review, which is included in the estates paper.
Okay, thanks, Paul. Right, in terms of the next item, it's minutes of the Primary Care Commissioning Committee meeting, which was held, which seems like ages ago, on the 5th of November. And if you recall, that was basically to look at the request to close the Sandyway branch surgery. And those minutes were circulated prior to this meeting. Has anybody got any factual inaccuracies that haven't been picked up in those minutes? If not, then can we agree them as a correct record? I'm not seeing any seeing lots of nods, but not any shakes of heads, so that's lovely. We'll obviously be using those minutes anyway for the, probably they'll be part of an appendix to our next meeting, because I believe that's when the Sandyway proposal is to come back to the committee. So any matters arising from those minutes will be dealt with at the next meeting, not at this one, if that's okay with everybody. So if we can move on then to the action log, which is page 14 of your packs. The first item, A7, Neil and I were to meet with regard to the review of enhanced services, the funding of which has to be agreed by the governing body, and there's a paper that Tanya has done on that on the agenda today, so we can take that off the tracker. The second item is future meeting dates, which we've managed to secure our meeting dates all on a Thursday, which was something that our general practice colleagues thought would be really helpful. So that can be taken off the tracker as well. The next item is about the additional roles reimbursement scheme. it says to bring to a future committee an anonymised summary of the requests agreed against the scheme and the reasons for agreement. We've got this on the agenda, but it doesn't actually fit that. What do people think? Has anybody got a comment on that?
Yeah, Pam.
Yeah.
We will bring the updated copy next time. So it's because we didn't have a meeting, so we'll get together and bring it to the next meeting, or we can send it out with the minutes later on before the next meeting, whichever you prefer.
Okay, thanks, Chris. If we send it out before the next meeting, we can take any comments on it at the meeting. If you like, Chris, that'll be good. Thank you. The next is the primary care risk register, which I assume is going to come to a future meeting. Neil, is that right? Yeah. Do we need a timescale on that?
It should be able to come. We're doing a revamp of the risk registers for the various CCG committees. So I'd suggest if we bring it to the next committee, which I don't think it's till July, is it? If I recall rightly, then that will be complete, and that will allow us to factor in the updates we need to make for primary care into the quality safeguarding and performance committee as well at the same time. Okay, that's lovely. Thank you very much, Neil. And the final one is the GP patient survey, which I assume will just come to a future meeting when does it take place? When do we get the results? They're only annually, aren't they?
They're annual, yeah. So the survey runs normally January to March, and then the survey results comes out July time, July, August.
Okay, thanks, Dean. That's really useful.
Pam, it's Louise, because I think that was an action against me, wasn't it, for Healthwatch information as well?
Yes.
Actually, our wider survey that the analysis is just being crunched through as we speak. So as soon as we've got to that part, we will be happily sharing. So that may fall between committees. As soon as we've got it, we'll share it.
That's lovely, Louise. Thanks very much. Because some of that goes to the quality committee as well, doesn't it?
Yeah.
Yeah, that's lovely. So has anybody else got anything on the log that they want to say, or are they okay for me to move on? Okay, I'm going to move on. The next item on the agenda then is the committee annual report. I'm not proposing to go through it in great detail, except to say that on page 3 of the report, it actually says at 1.6, this report was reviewed and approved by the committee virtually. Well, it didn't need to be done virtually because we've got this meeting, so that needs to change. And also it's been pointed out to me that it says we should have 2 independent lay governing members on the committee, and we've actually got 3. So I've flagged that already, and Neil and I had picked that up. So we need to do something about the terms of reference of the committee. But has anybody got any comments or any questions they want to ask on that report? No, nothing. Okay, it's quite straightforward. It's a record of what we did over the last year, and it'll go to the next governing body meeting just for their information. So if I haven't got any queries, I shall move on to 2.2 on the agenda.
Pam,
yes.
So it's Dr. McGregor Smith here. I'm just thinking, I didn't know whether I was supposed to raise or just highlight the conflict of interest, which obviously is in the details anyway, because in the report it does talk about meetings that I have not attended and haven't listened into, although apparently I would be entitled to, should I wish, about the potential, the application to close Sandy Way surgery. But I just wanted to make sure there was no question that anybody thought I was not raising that as a conflict of interest. I mean, there's no decision to make here, but it's just that it is talked about in the report.
Yeah, it is in the report, and I think at the end of the report it actually states who was at which meeting, and it shows clearly, Fiona, that you weren't at that meeting.
Yes. Yeah. Okay.
So, yeah, that's fine. Okay. Right. So I can move on, can I, from that? I'm just checking the box. Yes, good. To 2.2, which is the primary care commissioning update. I'm very aware that there are some tenuous conflicts of interest in here as well, because it's about primary care. But as it's very much a report on what's happened, it's an update to us. I'm quite happy for that to be dealt with by you just actually raising issues or raising questions. I don't think we need to exclude anybody from this debate. However, it is a report for information, so I don't expect that we'd have huge debates on it because what's happened has happened. So Chris or Dean, who are going to introduce that? Who's going to introduce the paper for me?
So I'll just make a start, and then Dean can introduce himself and fill in any blanks. So just to
Chris, you just need to know that we've all read the papers.
Right.
So if you could just make just highlight for us what are the big issues for you and what you actually
that's
want
what
the
I was
committee
going to do.
Yeah, thanks.
So it is for information only. So again, we said we'd introduce ourselves. So I'm Chris Lees, Associate Director of Primary Care for the CCG. The bit that I just wanted to highlight in the paper were later on. So the awarding of general practice resilience funding to practices, which the CCG worked with our ICP colleagues to do in March, and that funding has all gone now to general practice and PCNs that bid for the money, and the additional spend for supporting general practice during COVID. And you can see in the paper an appendix of all of the PCNs apart from one who have spent the money and what they've actually spent it on. So that was completed and in order. So that's useful to see additional funding going into general practice at this particular needy time. And LMC colleagues were involved in both of those. I don't know if Dean wants to add anything else to highlight other sections of the paper, but they were the main ones for me, Pam.
Okay, thanks. Dean?
No, there was nothing I was going to highlight. It's all in the paper, so it was more if anyone had any queries or questions.
Okay, has anybody got any questions? Dan, you've got a question.
Yeah, hi, it's Dan Howcroft, one of the secondary care doctor governing body members. I was just really interested about the resilience fund and particularly the supporting primary care. So we've obviously asked all these practices to explain what they're going to spend the money on, and I think you mentioned that has been done. Have we got assurance that what they said they're going to do is what they've actually spent the money on, or is that going to be coming further down the line?
Yeah, so what will happen is the practices or PCNs, depending if it was a practice or PCN bid, will sign a memorandum of understanding. And because this funding is delegated to us by NHS England, so I'm hoping Carla will nod when I say this, that is what NHS England used to do. So each practice and PCN would sign an MOU. And then in June time, Dan, we will ask for an update report against what they said they were going to spend, which again is in line with the usual reporting from NHS England. And I can bring a summary back to the committee to see that spend has been followed through. But in between times, the primary care operations team will keep that going with the ICP to make sure that it's in train. So yes, there will be an update and a report.
Okay, Leslie, you've got a question.
Yes, I'm Leslie Appleton, a governing body GP. Just a quick question about St Werburgh's sort of reopening to new patients. I was just wondering whether this had been communicated to the membership and that they're aware that they can redirect sort of homeless patients to the practice. And also, I suppose, we talked about, obviously this is a West Cheshire provision, and I know it mentions sort of briefly about looking at the provision for homeless across Cheshire. I was just hoping to have a little bit of information about that and where we're up to, really. Thanks.
Shall I pick that one up, Chris? Yes, St Werburgh's did have a list closure. They are now back open and taking on patient registrations. I'll make a note to send a communication out to all of the West Cheshire practices just to make sure that everyone's aware that the service is back open and available for registrations. With regards to the wider commissioning, it is something that we are aware of and have spoken about within the primary care ops team, that we do need to look at the provision of homelessness services across Cheshire and look at what's in place and how we're going to have those commission intentions going forward. So I do think it's something that will come back to primary care committee at a future meeting. It's on our to-do list.
Thanks, Dean. Gwydion, you've got a question.
Hi, thanks, Pam. Thanks, Chris. It was great to hear about money going into primary care and commitment to continue with that. It's a quick question about the general practice resilience funding, and I've asked similar questions before. Often these requests come through at short notice, and I know that's a national issue with this. Can we speculate on when we might have opportunities for the practice to access other tranches of money, because we've got 79 odd practices and there's 20 odd practices that have engaged, which is great. But I'm looking obviously to try and maximise the opportunities for the residents of Cheshire. So if you might be able to comment on that, that'd be great. Thanks.
Yeah, so I'll do general practice resilience funding first, and hopefully Carla will nod or go like that if I'm not saying the right thing. So my understanding, Carla, was this was the final year of general practice resilience funding in that form. Is that correct?
Yes.
Yeah, okay. But there is, Gwydion, I don't know if you saw in last week's bulletin, additional support COVID funding money. So the other bit of funding that's in the paper, the 150 million of which the CCG will allocated 1.896 million, there is another tranche of that coming. We're just waiting to see how much that is and the guidance around it. So Neil and I are both chasing it each day, but yes, there will be further funding, but it hasn't been released to the CCG yet.
Okay, thank you very much. Thanks, Chris, and thanks for the questions. Has anybody got any other questions or any other comments on the paper? There's quite a lot in it, but lovely. Okay, so we're asked as a committee to note the updates in respect to primary care commissioning and contracting, which I'm sure all of you will agree to. So that's great. Thank you. I'm going to move on now to the primary care quality update, which again is another paper that is about services provided in primary care, but our primary care colleagues, I don't see that as a great conflict, so would welcome any questions or anything they want to raise about that. So I'm assuming that Katie, you're going to talk to us about this, yeah? But assume again that we've all read it.
Thanks, Pam. I will assume that you've all read it. I've brought the paper today to committee in a slightly different way. Previously, it's been included within the overall paper that Chris and Dean submit, but just with the timings of committees this time round, and because we haven't had primary care committee for a number of months, I've submitted it as a full report, and welcome any feedback in terms of whether that depth of information is what's required at this committee or whether a more summary report would be better. Obviously, primary care quality, the assurance of it sits with the Quality, Safeguarding and Performance Committee. So would welcome any questions that this committee has for me on this paper.
Okay, have we got any questions? Gwydion, you've got a question.
Hi, thanks, thanks, Katie. It's just a question about the flu. So the flu data, I think, was to the end of January, wasn't it? And to ask on those different patient cohorts, how the coverage percentages may have changed. You know, you may be able to give us some data, or you may be able to speculate. And then it's really asking, because obviously the number in pregnant women is quite low. It's a long time since I did public health, but with different viral illnesses, you need different coverages to have effective herd immunity. And with flu, I think it's quite high. So I think you're actually aiming for 75 to 80%, and there may be someone in the room that can correct that. But taking that, it's just thinking, well, how do we actually make sure that the next set is even better? So thanks for that.
Thanks, Gwydion. Yeah, obviously the pregnancy uptake is the lowest out of all the cohorts. That is reflected across England. It is a harder to reach population. Obviously the pregnant women weren't accessing acute trusts as much as they have done previously. So we've got a number of actions. We've invited the midwifery teams to join the flu group, the CCG flu group next year. And there's also been new national guidance that's come out that has put more emphasis on the acute trust maternity providers to vaccinate pregnant women. So it is something that is on our radar, and it's certainly something that's been looked at nationally. Interestingly, one of the things that's transpired from some of our analysis of data is that the workforce, the NHS workforce flu uptake that information doesn't come through onto the primary care clinical systems. And so any pregnant women that are vaccinated because they work in the NHS isn't picked up in that data. And obviously because of the demographic of the workforce within the NHS, that would improve the data. So sort of the assurance that probably much higher rates of pregnant women are getting the vaccinations, it is an area that we are acutely aware of and will be working on next year to improve.
Okay, Leslie, you've got a question.
Yeah, mine probably follows on nicely from that, actually. So obviously, I was going to talk about the pregnant women, but also the ethnic minority population and the figures being really quite low with them. I wondered whether, obviously, we've done a lot of innovative things, haven't we, with COVID vaccinations, trying to get into mosques and just making it more accessible, whether that was something that we were going to look at for the flu vaccination programme moving forwards, because there's been a lot of lessons learned.
Yeah, I think there's an awful lot of new knowledge and lessons learned within primary care and PCNs that hopefully will carry over into the next flu season. It's certainly something that we'll be looking to support moving forward, and hopefully some of the attitudes within some of these harder to reach communities will have changed and will be easier to reach than have been previously.
Okay, thanks, Katie. Dan, you've got a question.
Yeah, just around the video consultation platform and the fact that it's now being funded, I believe, by the CCG from the paper. What is there an anticipation that most of the GP practices will continue to use that beyond, or will they start to use their own platforms? And I guess if they are going to move, is there a potential risk in terms of how that plays out and if there's going to be any disruption of services that we thought about?
So I didn't quite catch all of that question, but I'm not sure if that's something that maybe Dean or Chris could pick up around the platform for the virtual consultations. Was this?
Yeah, so with regards to online consultations, there's a number of different platforms, and the CCG IT team are working with the GP practices. So in effect, there will be a suite of options that practices can choose from, each with similar functionality. That is separate at the moment to the video consultations. So as you rightly say, video consultations is funded by the CCG for this year. As we go through the year, we'll have to see how that funding plays out, because I believe it's actually national funding. But there's a GP contract requirement for practices to have both online and video consultation functionality. So it's more around how that will be funded as we go into next year. That I think will be the key question that we'll have to deal with as we go through this year.
Okay. Gwydion, you've got another question?
Thanks, Pam. Quick question on the childhood IMSS. So looking at the table, there are some worrying trends with practice 3 and 7, in that proportionally the people waiting are a big proportion with respect to their list size. And there's not been much movement from the December to the February. So I suppose there are two prongs to the question. The first is asking, why are these smaller practices seemingly having a more significant problem? And also, why isn't there faster movement there, please?
Thanks, Gwydion. It is something that I am very consciously keeping a very close eye on. We use the waiting list data because it's the most up-to-date data that we can get in relation to childhood immunisations. You can see from practice 1 that with having a little bit of engagement with the practice, they successfully reduced it. Obviously, during the last few months, a lot of the primary care workforce that would normally be doing the childhood vaccinations have been very busy doing the COVID vaccinations. So that's another reason for that close scrutiny on it. What we did find with practice 1 is that the data isn't 100% accurate, and that sometimes actually it's the CHIS systems that need updating. And that's why I brought it here. We have raised it at PCOG, and it is something that we are going to work with the practices to make sure that they have plans in place to address this and reduce that waiting list, so that we've got no risk of outbreaks of vaccine preventable diseases.
Okay, thank you.
Sorry, Pam, that doesn't answer my question, I'm sorry. So if we're looking specifically at practice 3 and practice 7 in table 2, so you've got list sizes of approximately 7,000 for both of those practices, and you've got December waiting list close to 100 for both. So proportionally, that's high. So if we're talking about trying to prevent isolated outbreaks of infectious diseases in younger children, that's concerning, because you've got a lot of unvaccinated people proportionally, and the movement from the December to the February is minimal. So, you know, in over a year, there's no progress.
And it's in a 2-month period. It's not improved. Yeah, you're absolutely right. So it is something that we're going to work with those individual practices to see if we can get an action plan together and share the learning that we had from practice 1, who implemented in a very short period of time an incredible improvement plan to reduce their waiting list. Practice 1 is a particularly deprived area with a lot of non-English speaking families, so they've always historically had a huge waiting list. So I think the success from that can be shared with the smaller practices so that they can try and implement some of that learning. But I'll bring an update to next committee to give you that assurance that we've seen some improvement with those practices.
Thanks, Katie.
Yeah, I was going to ask you for an update. That's really good. And I've got some questions from Fiona. I think you've got 2 questions, Fiona.
Yes, thank you. So Fiona McGregor-Smith. One is kind of along the same lines for, I suppose, with quality. On 1.7, it's under the section about the Care Quality Commission. There is comment about the quality team monitoring and supporting 8 practices that are being looked at by the CQC. And I just wondered, is that how that's done? Is that do the practices know that they're being monitored? Is there regular input? Would they be providing advice? I mean, it's obviously a very wide range of areas, but there was one question about, you know, how actually the practices are aware of it. And this is my second question, which is entirely different, was about the Valpwait pregnancy prevention programme. Because there is some difficulty sometimes engaging with secondary care, because the idea is there that anybody who's still on Valpwait and who might get pregnant has to have that drug signed off by secondary care. And historically, the epilepsy consultants, who were also very busy, were trying to pass those patients back to primary care, and some of them have been very difficult to engage with, to take the patients back in order to do an annual sign-off. And I just wondered, had there been, that's a problem that has landed at primary care's door, but it's very difficult for primary care to resolve. And I just wondered whether that was an ongoing issue, or was that something that the quality team had been able to sort out?
So if I address both those queries. So the first one, the CQC query around those 8 practices. So the CCG meet with the CQC to discuss any practices of concern. Obviously, they're not doing their normal inspections at the moment. So those practices were ones that, for a number of reasons, are having a closer radar, and some of them will have had telephone calls from the CQC, and other ones are just being monitored remotely, just to ensure that there aren't any further incidents. Some of them are sort of ongoing problems with those practices, and certainly the clinical leads that work with the CQC do have conversations with those practices. With relation to the Valpwait one, this is a piece of work that the meds management team have been doing and reported back to the primary care incident meeting. I can bring further details on that to the next committee. This was just a sort of briefing to let you know that it is on our radar, but there is lots more work to be done with that.
Okay, does that answer your questions, Fiona? Yes?
Yes, it's just to make sure that the practices who are being monitored know they're being monitored, but you've said yes. and it was just to highlight that that issue is sometimes tricky for primary care and Valpwait, the sodium Valpwait issue.
It's my understanding practices that have a requires improvement from the Care Quality Commission, and what will happen is when the Care Quality Commission report comes in, if there's anything that would be of interest to the CCG because of, it's part of the contract, that's the bit that we would manage. Is that right? I think that's right, yeah. Yep. But the Care Quality Commission will also be monitoring a wider action plan. But for us, we tend to focus on what's in the contract that we have with general practice in terms of that monitoring. Okay.
Pam, could I add one comment to that?
Yes, Dean.
Just to clarify that of the 8 that we've got, some of those will be pre-COVID. So where you've just touched on the fact that if there's any requires improvements, the CCG is made aware of those between within the primary care team as a whole, so quality and the contracting team, we will then go out to the practices and work through what their action plans are. On that list, some of those, as I say, predate COVID, and CQC haven't gone into to in effect draw a line under it. So as CQC get back up to speed as we come out of COVID, there will be a bit of tidying up on actions that are coming up to 2 years old. So I would expect that list to shrink down quite quickly.
Okay, lovely. A final point from me really is that I'm aware now that quality sits in the Quality and Safeguarding Committee, and so I'm going to meet, Paula, you don't know this yet, neither does Neil. I want to meet with Paula and Neil and Christine, who chairs the Quality and Safeguarding Committee, so we can decide what goes well, how we repeat things, because we're going to have some quality issues raised here because it's the right place for us to do it, but we need to decide what comes here, what goes to the Quality Committee, or whether we duplicate or how we do that. So hopefully when we come back next time, I can bring a report back which says this is how it's going to be monitored, this is how quality in primary care is going to be monitored. So that should make things a bit clearer, because I don't think we need to duplicate everything, but it's an important aspect of the work of the committee is quality. Okay. So in terms of that report, we're asked to note the update in respect of primary care quality following the receipt of the report at the Quality and Safeguarding Performance Committee, which is charged with the duty in relation to quality of primary medical services. So we can all accept that report unless I see anything different in the box. No? We're okay with that recommendation. Thank you. Right, so move on. We're moving on to the primary care estates update. James.
Hi, Pam. Thank you. Just an update on estates at the moment. As some of you, or most of you, should be aware, there was a national data gathering exercise that had been done in conjunction with NHS England, and we were on phase 1. Unfortunately, due to COVID and the pandemic situation, the scheme was postponed, and this is a sort of a timeline of when we're hoping that it will restart. We have actually been advised since this paper was written that we are going to be meeting next week to talk about comms, about the recommencement of the programme. So that's a real positive thing, and I will be sending out correspondence to GP practices on that. So that's just an update on there. 1st of April as well, the rent reimbursement process that was managed by NHS England from the inception of the CCGs up until sort of 31st of March has now transferred over to the CCG. We have a couple of members of staff that are engaging with practices now as far as rent reviews. Historical problems or issues that we've had with practices will still be managed in a joint way with colleagues at NHS England, but that's but as far as the process is concerned, we're managing that quite successfully now. We've recently been engaging following some guidance from NHS England regarding primary care networks and the demand for space to accompany the additional roles that have been funded by NHS England. And we have some guidance that we've now sent out to practices, and we are engaging quite positively with a number of PCNs so far, just to sort of say we need an estate strategy, we need a clinical strategy. It's a sort of a starter for 10. We have got some good information. We've already had one that's been acceptable, and we are sort of moving forward with that. So it's really positive that we're actually looking at the wider picture of PCN and how they engage with other organisations within that, whether that's other GP practices or local authorities and other third-party sectors. So that's been really welcome from our perspective. Improvement grants as well. We've got the improvement grant situation starting and we have about 7 bids in so far. So I can update the group next time once we've actually got the draft submissions. This year, NHS England have asked for early submissions, just on a very high level, with obviously more detail to follow at a later date. But it's quite positive that we've had 6 or 7 of them so far. Just an update, Holmes Chapel. Holmes Chapel was a ETTF scheme that started from the funding in East Cheshire CCG. The ETTF scheme was in 2016, so it's been quite a long process in getting the work completed. I have visited the practice. It's been really, really well done, and we now have also we're getting the district valuer to just sign off that scheme at the moment, so that's fine. Blacon is a new GP practice development that was approved by West Cheshire CCG and has currently been housed in the Holy Trinity Church Hall for a number of years. There's, in conjunction with Sanctuary Housing, there is a development that is being built and it's due to complete, I think it's March next year, and it is they've obviously engaged with Sanctuary Housing, and it's I think we're up to sort of foundations and some of the walls at the moment. The practice has requested as per section 14 of the premises directions for professional fees and related costs. So these are generally legal fees and professional advisors in assisting the practice in getting the premises to their desired standards. So we've had an application from them. The application has gone to the Estates Committee. It's just short of £24,000, so it is something that is generally acceptable through premises directions. We've done a due diligence of the legal costs, etc. And the final thing is, obviously, we've in conjunction with the PCN estate strategy, we've engaged with Middlewood, who have looked at some reviewing of East Cheshire occupancy of their premises, and as a consequence have applied for an increase in GMS space from East Cheshire Trust leaving their premises. So we have recently reviewed that at the Estates Committee.
Okay, thanks, James. Before I ask any questions, just to say I am aware still that we've still got this potential conflict of interest for GPs and practice managers in respect to this, but I don't think anybody's connected with the practices that James has named, unless I'm mistaken, I think. And I'm certain that we've got to make a decision on Blacon, but there is no conflict of interest in respect of that. If people have one, will they just let me know in the box, please. Meantime, Gwydion, you've got a question on additional roles and estates.
Did Dan beat me to the question? Does he have one ahead of me? No.
Don't think
Quick question.
so.
Thanks, James. It's just your view, really, because obviously there's a lot of money coming down for additional roles. So Mere Park is a very small practice, but we've had a number of extra members of staff. And it's just asking you how you think that is going to impact on estates and whether or not there is actually commensurate funding coming down to meet the estates challenge of having these additional personnel in primary care, really, because there's a big shift, isn't there, from having people in secondary care into the community. And I think that is going to be a problem. It's asking your opinion, are the funding streams matching?
There is meant to be a review of primary care estates in the summer of this year. This may join up with the data gathering exercise, and that should allow NHS England to look at funding, etc. Hopefully that will be tied in with the revisions of the premises directions, but I live in hope yet, and I'm not holding my breath. But the directions are obviously constraining what is allowed to be funded from an NHS perspective. I think the guidance that's come down from NHS England is okay at a very high level, but But as you look at each individual circumstances within the PCNs, they are always challenging and always difficult. There is an assumption by the paper that the additional roles could sit in other locations, and that may be appropriate, but again, equally, it may not be appropriate because there needs to be that clinical role with GPs and other clinical services. So as far as funding, I don't know at the moment. You know, we're just not sure of what the new guidance is going to be coming out, possibly in the summer, possibly the autumn, by the time we've just had hints that there is information coming.
Okay. Before I go to Dan, I know that Neil's got a point that he wants to make that's related to that point of Gwydion's. Neil?
Yeah, it's not related to estates, but we regularly have this debate with PCN or internal colleagues about additional roles and how it's supported. For IT for this coming year, what we have done within our plans is secured funding to support the additional roles that we know will be coming online this year. So that's in terms of additional hardware and software, but also the support required by growing our primary care workforce. So we've been able to find ways for IT, but as James alludes, estates is a little bit more challenging potentially.
Okay, thank you. Dan, you've got a question?
Yeah, thanks. It was about the primary care estate strategy, and I may have missed this, but obviously it refers to the NHS EI guidance or guidelines and all the various things that are coming out. And then we talk about the understanding the PCN estates and what would be required, you know, what's evidence for requesting new improvements of things. I guess with a little bit of a nod to Gwyd really in his with his other hat on. I don't see much here in the way of environmental sustainability and whether we're looking at that as well, because I don't know if that's coming from the guidance, maybe it is essentially, but if not, should we be looking at that from a Cheshire perspective anyway? So when we're assessing things, we're looking at that side of things too.
I think that's a really good idea, and I'm sure, yeah, Gwydion will agree. Yeah, can we put that in? Is that possible?
Yeah, we have a climate change group of which Gwydion and myself are both members of. So we do look at climate change impacts and environmental sustainability going forward. We are looking at trying to sort of come up with environmentally friendly schemes, and some of those are demonstrate financial benefits as well. So it is something that is on our agenda, and obviously we have a primary care, very strong primary care representative on the group as well. So that is something that we are looking at as well.
Thanks, James. Leslie, you've got a question.
Yeah, mine's just a very brief question, just because I've not had any experience with it. Just because we have to agree to nearly 24,000 reimbursement to the ELMS, just whether or not this is a reasonable ask for professional and legal fees compared to other builds that have happened. Just for my knowledge, really, as far as agreeing the fee, really. So.
Yeah, so we do a due diligence. We've had the quotes back from the practices or from the practice on the schemes, and it sits within, we're allowed to claim up to 12% of the build cost for professional fees, so it falls within the remit. We have approved other schemes in the past where they've had build costs and legal fees when renegotiating extra leases, etc., etc. So it is taken on a case-by-case basis. It's clearly not an unlimited fund, but we do a due diligence on that, and it's within the acceptable standards.
Good. Thanks very much, James. If I recall correctly as well, the move from the church into the new build is going to be a saving to the clinical commissioning group because the rent's less. Yes,
that's right.
Yeah, I thought so, which is we found quite remarkable when it was debated at the Primary Care Commissioning Committee in the West. So has anybody else got any questions, or can I move to the recommendations? No? Okay. So we're asked to note the contents of the report, and we're asked to approve the financial support for the new Blacon project. Does everybody agree that we make those payments? Yes. Thank you very much. That's lovely.
Thank you.
So moving on to 2.5, item 2.5. I'm going to mention again, sorry, like a broken record. The 2.5 and 2.6, we've definitely got conflicts of interest because there's a direct pecuniary interest for primary care colleagues. So I'm going to say that I'm quite happy for them to answer questions if we feel that it would help if they are asked a question in terms of extended access or enhanced service review. You can comment on the process, but what you shouldn't be doing is influencing what actually the outcome of that process is. So if that's okay with my primary care colleagues, I think that's probably the best way of handling that conflict. So let's move to the extended access update and approach. Tanya.
Don't think Tanya's
here. No,
come on yet. I've just messaged her just to check. I can start if that's acceptable.
Yeah, or do you want to? Oh yeah, I'm fine to do that. Or do we want to do the finance update and wait for her?
Yeah, that's fine. Yeah.
Is that okay with you, Lorraine, to do the finance update now?
Yeah, that's fine, no problem.
Okay.
Okay, so from the paper, I was just going to pull out a few key points on the basis that everyone would have read the paper. So table 1, we can see that the local primary care, we've got an underspend of 2.6 million. So the main reason we've got that is when we were planning the budgets, the delegated was projecting an overspend. So in order for primary care to be a balanced position, we planned that local would absorb the deficit. However, due to COVID, we did receive a retrospective allocation, which then brought the delegated back in line. Therefore, that's why we've got the underspend showing in the local. We've also got there the Primary Care Access Fund. Again, due to COVID, lots of the planning was halted, which is what's made up of the £1.2 million underspend there. So if I just move slightly further down, the delegated is almost balanced. And that was due to the retrospective allocations that we received. Additional roles. The additional roles that we received was based on £7.13. We actually received 60% as an allocation to the CCG baseline. The whole of the 3.2 million is actually been utilised. So therefore, the 40% remaining, we've not had to draw down from NHS England. A lot of the plans haven't been able to be developed from the PCNs with the workforce plans, just on the basis that COVID sort of impacted on all of those plans. We're now in the process of asking for their 21-22 workforce plans, and I think they need to be in, Dean might have to help me out with this, I think it's the end of May. Just move slightly further down. There's a table there which is based on all of the allocations that we've received in year. So we've received for local primary care approximately £2.1 million, which is lots of stuff that we've bid around. A lot of it is mainly GPIT. And then in the delegated, we've also got the care home DES and impact and investment funds, which is a further 2.6 million that's been invested in to the delegated primary care. Moving further down, so the financial planning. So we're only just receiving the sort of final planning information. So we're hoping that next time we'll be able to bring a table of all the up-to-date position for the planning for the next year. And unless anybody's got any questions.
Okay, has anybody got any questions for Lorraine? No questions? That's the quickest finance report I think I've ever has ever gone through a committee that I've been in.
Thank you.
So with the ask of the committee, if I've not got any questions, is that we actually note the financial position reported at month 11 and note the financial risks currently facing the CCG. Is everybody happy that we've done that? Yeah, because you've all read the report and they're all in the report. Lovely. So we can agree that paper. So I'm reliably informed that Tanya's joining us in 4 minutes time. So is Kevin here? Do you know if Kevin? I haven't seen Kevin.
Kevin's actually on. So the plan was that I would introduce the paper, and we have Mike and Jade who are in the audience, or should be in the audience, but as they're not expecting to be here yet, may well not be. But I'm quite happy to take the paper I would just forewarn that if you want to start getting into detailed technical parts of IT, then I'm probably not your man. But I can quickly go over what's in that IT paper.
Are people okay to go through the IT paper, which is the next paper on the agenda at 2.8? We are well ahead of ourselves, I must say. And
Mike has joined the meeting, Neil.
Okay, so thankfully I may have some wing people to help me if we do start asking detailed technical questions. So I think that the IT paper we would like to suggest is a good news story. We know that, and I made this comment to someone recently, I'm not suggesting we don't have issues with IT occasionally and systems being slow and going down, but I'd like to think over the course of the last 12 months we've seen huge investment in IT, and the paper describes some of that investment that's continuing going forwards. Kevin and team continue to work very hard with people like Dan Jones as a clinical lead in putting in bids to NHS England and NHS Digital to seek additional investment into IT in Cheshire, and the paper describes some of those areas and has a fairly detailed table at the end, which has previously been shared with the Cheshire to keep them appraised of this. I would draw attention particularly, I think, to 1.1 in the paper, because this is something that has been a challenge. We know that Cheshire was one of the early adopters of digitisation of paper records, and within the budgets for next year, this year should I say, we are obviously looking to invest in an ongoing service, and Mike, I know, has been very close to this, so if you wanted to ask more detailed questions about the Lloyd George digitisation project, then we can do so. Similarly, obviously, things like Office 365 are nationally procured, have a significant cost implication of being procured, but we are forming part of that. Just in terms of some of those wider things down there, in terms of trying to help practices to move forward around things like the clinical template solutions and some of those innovation bids that are featured in section 2. As I said earlier, I think it's generally hopefully a good news story that's seeing a gradual improvement in the IT available to practices. I know some of the GPs will come back to me in a minute and point out some of the flaws in that statement, but hopefully it appears more positive than it might have done 18 months ago in terms of what we've got and where we're going. So I'll open up to questions, and I've bluffed long enough that hopefully Mike and Jade are both on the line to answer them as appropriate.
Okay, thanks very much, Neil. I'm conscious of the fact that some of the systems that are mentioned in this paper, I've got absolutely no idea what they do or how they work or whether they work or not. But it would be great to me if you could, my colleagues in primary care could highlight any issues that they've got with them. And also, just a question, Neil, from me, how is primary care represented where the decisions made in order to invest in these systems? How does that work?
Yeah, some of it depends on the decisions, and there would be consultation via particularly PCN network groups to do some of that. And Mike might be able to give some examples of how some of the engagements happen on particular projects. We do have a clinical lead who, for IT, Dan Jones, who similarly, and I know as I'm sat here, I keep seeing emails flashing up from Dan, who's got a particular project at the moment, and he is engaging with various GPs from dotted around Cheshire that I can see responding to Dan's inquiries. So there is various ways. We don't have a formal committee structure, if that's what you're asking, which might be something that the committee wants to recommend in terms of a more formalised way of doing it if people don't think it's working. But I guess the positive has been that because we've been successful in the bids over the past year, it's been less a case of competition. We've been able to invest in more things than perhaps in previous times. But I'm sure that Mike and Jade would welcome suggestions if particularly the GP representatives here think a more formal approach to identifying what we need and which priorities to go for is a better way forward.
Thanks, Neil. That's fine. Gwydion, you've got a question.
Thanks, Neil. I'm saddened that you've had your backup now, but anyway, it's really good, and there's a lot of money going into it, which is great. I suppose there's a question about the pilots with recording the call conversations, and also the way that telephony is handled in primary care is like something out of the dark ages. And especially with all the additional roles, it would be really helpful if patients can actually access these additional roles. So social prescribers, physios directly, because at the moment what happens is that they have to go through receptions in different practices. So it's asking really, when are we going to start looking at call handling software? Because the big difficulty for GP as providers is that we are locked in to using something which is acceptable to the NHS, and that prevents the more proactive partnerships from moving forward. So it's just, it's great, and there's been a lot of progress in the last year, no question at all about that. But asking really, when are we going to have that call management software? When are we going to make sure that our ability to manage flow improves? Because as I said, with the additional roles, it's great to have these roles, but if the bottleneck is still reception, then that causes problems. Thanks.
Thanks, Gwydion.
Yeah,
Paul, sorry, do you want to pick that up, Neil?
Yeah, I was going to say, I don't know if Michael Jade has an immediate answer, but I think we can certainly have a look at what's out there. I must confess, I've worked in the NHS 12 years, and before that worked in financial services where we had lots of big call centres, and all of that was, working fluidly then. So I've no idea how much better it is 12 years on. So I can see the point you're making, that having a bottleneck of one small group of people isn't sensible. But I say, Michael Jade, shout up if you do know of anything immediate. If not, we can go and explore who in the NHS is at the cutting edge in that space.
Yeah, I think it's a complex issue, because obviously you have to take into account the fact that NHS Digital obviously pushing online consultation and things like that to kind of make your patient flows. The other issue you've got to take into account is the fact that not all practices are using the same phone systems. So quite a few practices are using the one provided with the CSU and the CCG. So I'd be interested to know more, in getting more detail about what you'd actually like to see. And is that something you can follow up with? An example of a call handling system, or an exemplar or something like that would help you?
Yeah, so very briefly, if someone rings my practice, I would like them to have the option of going straight through to the pharmacist, or going straight through to the physio, or going straight through to the social prescriber, or going through to someone that can book the patient in with those services, because it's all about care navigation. And at the moment, the care navigation is reliant in most instances on, in the worst case scenario, being directed by the GP. So in which case that patient goes all the way through the system, hits the GP, that never needed to see that person to start with, just to navigate them to the right care. Or they go through reception, and with the best will in the world, there's a variance in reception. So it's looking to front load it and have a more efficient and more consistent offer, and that makes sense across a large patch. So, Dan might be able to help us with this, because, in the private sector and agencies like Bupa, they have been ahead on this, obviously. So that was what I was thinking, Mike. Thank you.
Okay.
I know Paula wants to come in with a question. Is it related to that, or can I bring Fiona in, who has a comment that does relate to that? Paula, is yours something different?
Different.
Okay, so are you all right if I bring Fiona in now, and then I'll bring you in after that? Fiona.
Hi, thanks. So listening to Gwyd, I was thinking that it's probably quite important to involve the communications team here, because we have a lot of variability in patients' knowledge and ability to use IT as well, and still quite a significant number of patients who think that the entire system is being developed around blocking them getting to the GP, which is not true. But it is often, as Chris says, that actually you get to the GP and they were not the person who needed to be involved at all. So I do think there might be quite a bit of, getting the comms and engagement team might be needed at some point to help just advertise it and reinforce that it's there to help, not there to hinder patients, because I think that is part of the problem. And my other comment really was to say, thank you for the money that is going in. It is very gratefully received. Hoping that it will continue at that level, because what we have learned from COVID is how much can be done. Not everything can be done, but what can be done using IT solutions, which hopefully will give us a little bit more time to spend with the people who you do actually need to see. And so it is really important that that is supported ongoing, really, because we've learned, I think, in primary care how much we can do effectively through IT solutions.
Okay, thank you, Fiona. I know that also Leslie wants to come in on this now. Sorry, Paula, I keep pushing you further down the list. Leslie, is that a comment on this as well?
Yeah, just very quickly, it probably is being taken into consideration anyway, but just that we're not focusing on telephone calls as far as booking appointments as an online offer for all of these things as well, that you can. This is what people want. They want to be able to go on their phone, not have to speak to anybody, and book in with the person they want to have an appointment with, not sit on the phone for an hour or press redial to try and get their appointment. So I suppose it's just making sure that we have something along that offer as well.
Thanks. Okay, thank you, Leslie. Paula, over to you.
Thanks, Pam. I was just interested in section 3, which is about the contract extension in terms of the offer from Midsummer CSU. And I know I've heard at previous primary care commissioning committees, challenges about the availability of time when that is available, just, in order to be able to match when primary care's hours of operation. So I know the earlier start and the later finish, Monday to Friday, which is great. I just wondered what sort of thoughts and feedback and discussion there have been about considering other options in terms of flexibility around weekends and on call, because we have heard from practices that if you're in practice at the weekend and you need help, you need it rapidly. So really pleased to see the extension in terms of the hours, but just wondered what other discussions have been had about supporting across weekend working.
Okay, can someone pick that up for me?
Yeah, well, I know there have been discussions to try and work out the best solution that offers some value for money. There are, of course, on-call arrangements that do exist at bank holidays, etc., which can be used, and I must admit I've ended up using during the pandemic when practices have rung me to try and sort something out when they've been trying to run an additional clinic. I think the challenge of the full call centre offer is clearly the volume of calls. It becomes very expensive if you're having to staff a call centre to do some of these things. So that's where you end up with an on-call solution because there's just insignificant volumes. Now, if general practice at scale was going to be open Saturdays and Sundays, then it would justify doing it. But my understanding is the analysis hasn't indicated that that would be the case. Hence why there isn't currently a plan to go beyond the hours proposed. But other parts of the country do use Midlands and Lancs for wider hours than we're doing. So it's not that it can't be done. It's just I think the value for money assessment was it doesn't justify itself at the moment for the small number of practices that actually are running regular clinics there. And if in flu campaign season, for example, where people are running lots more things, we can look to extend in the same way we have been doing during the vaccination programme to put a more responsive service in. So happy to take people's views if they think that could be developed. But that's where this proposal came from. It was the analysis of what the need was and then the value for money next to that.
Okay.
Thanks. Can I just say, I think sometimes if sometimes it's knowing what's available. I know if I'm working a certain number of hours and things aren't available at those hours, I don't try to access those services. So sometimes the analysis doesn't always ring true, really, I guess, in terms of what the demand and the need is. So I think it's helpful to hear from Neil that there is a robust on-call response and that there is actually the flexibility if it ever needed to be scaled up. But I guess analysis for me is sometimes flawed because you don't use necessarily, you know, what's not there. And the risk balance for me really is about the impact on safety. I guess that's where I'm coming from. You know, I've heard colleagues talk about how challenging it is to be able to continue to deliver services safely in terms of access to records if you can't use your IT services. But you know, I think Neil's answer gives light to a few models should we need it, which is helpful.
Okay, thanks, Paula. So in terms of going forward with the strategy and services that we want to look at, do people think it's a good idea to have a look at an IT subgroup that does that? Yeah. I'm getting some nods and some not nods. Maybe, thank you, more nods. Maybe something Neil and I'll look at, seeing whether we can pull together a terms of reference with the relevant people that are working on IT at the moment, Neil, and see if we can pull some people in, have a look at what sort of things will be looked at, and see if we can put that together.
Yeah, just to be clear, there is an IT subgroup that works. I think that the point I picked up was about how do we get general practice.
That's what I mean.
To confirm it by, and so it's the broader church, isn't it, in terms of the reps from general practice with that LMC and PCN directors or whoever it might be, having the ability to feel they've influenced that.
Yeah, well, maybe we look at the terms of reference of the group, or maybe we just look at how we do it. Yeah, okay, that's lovely. So in terms of the recommendations for that report, if no one's got any other comments or questions, we're asked to note all the sections in the report for information, and I think we've done that. So we need to move back on the agenda to 2.5. I'm assuming because Tanya joined us.
I have, sorry about that.
That's all, it's not your fault, Tanya, it's my fault. It's that you're not due till 3:45, and we're about half an hour ahead of ourselves and 2 agenda items on top of that. So we're galloping through this today, which is really good. So we'll start off with extended access. Let me just go back to my papers. I'd already explained to members of the committee about conflicts of interest, so we've actually covered that already. But Tanya, just make an assumption, everybody will have read the papers. So if you can just highlight for us any issues that you've got in terms of it and really what you want from the committee, that will be useful.
Yep, sure. So to be fair, we're going to bring a more detailed paper around the kind of specific, I suppose, more complex issue within the paper to a future primary care commissioning committee. As you've already read the paper, the key issues really that we've identified within there is that the funding for extended access is moving over to the primary care network DES, so National Direct Enhanced Service, from April next year. It's been delayed, having previously been for launch this year due to the COVID pandemic. So PCNs are not likely to take on this work now until April next year, although there are some practices, some PCNs within West Cheshire CCG, old footprint as it were, who wish to take this on midway through this year from October onwards, which, as you can see in the paper, potentially will provide some, real kind of motivation for how the PCNs wish to work in West Cheshire, and also some potential improvement, in terms of service delivery for patients within West Cheshire. However, it will also come with some risks around, potentially service delivery in the transition, but also funding, delivering a service in advance of that national funding in the DES being agreed. So that's one key issue within the paper. The second one that really I wanted to draw your attention to is something that Dean has brought a previous paper to this committee around, which is those additional services in West Cheshire that previously have been funded through the Prime Minister's Challenge Fund amount of funding that we receive from NHS England. Obviously that funding will be being passed over to the practices through the PCN DARES from April next year onwards, due to the extended access amount. However, you know, we need to make a decision, and that's what the more detailed paper will come back to this committee as to whether they are still services that we wish to commission for the West Cheshire population, and if so, how does that compare to what we commission, you know, across the patch? Are we sort of comparing similar services to what's already being commissioned and out there in the other, you know, side of Cheshire? And then finally, if that is going to continue to be commissioned, you know, what potentially are those cost implications for us as a CCG? So the main ask really through that paper is to give you an update on where we're up to in terms of extending the current contracts, what the issues are in terms of taking that service on mid-year through West, and that this more detailed paper will be coming back to a later primary care commissioning committee.
Okay, has anybody got any questions on that extended access paper? No. Tanya, when will the paper come back? Do you know?
So we're scheduling that, we're hoping to schedule that into sort of June or July time, and that will give us enough time to carry out our investigations, gather all that information together, consult with the you know, practices and the LMC in West Cheshire, and to take it to primary care ops first, and then bring it through to primary care commissioning committee. So we're scheduling that in for either June or July.
Okay, so it should come back to us in July, end of July?
Yeah, and then that will give us, you know, if there are any changes to be implemented before West Cheshire wish to go live in October, that will give us some time to try and make any of those, you know, changes to existing contracts before then.
Okay. Right, I'm just looking in my little box. I've got a Neil, you want to make a comment?
Yeah, it's just particularly the point around the additional roles in the current Prime Minister's Challenge Fund scheme over in the West. I guess until we see the specification, the national specification, it's slightly tricky to form a clear position on it, isn't it? Because if you take something like Physio First, which is, you know, linked to the additional roles that are within the DARES anyway, you know, I would query why you wouldn't necessarily want physios in an additional role scheme. You may want them in the same way you want GPs or nurses or healthcare assistants or a range of other things. So without seeing the spec that's nationally linked to the DARES, it's quite hard for me to know what the answer to that query is.
Okay.
I don't know. Oh, sorry, Pam. I don't know if Dean wants to comment here, because we've had a little bit of feedback, haven't we, around the additional roles and the baselining, Dean? Yeah.
So the things that we'll have to factor in and probably in that more detailed paper, as part of the PCN DARES, we've baselined what the CCG is currently funding for physios, as an example. So although that service may change, you know, as we do a service review, we may find that there's a better way of delivering it, or it may need tweaking, which is all fair and something we could look at. But from a PCN DARES point of view, we are committed as a CCG to keeping the baseline numbers of physios that we have in place when we started the PCN DARES. So the crux of it is that there's going to be a funding question around, if all of the funding goes over into the PCN DARES, we're going to have a bit of a gap for the other services that are currently using that funding. And as I say, we've got a commitment to carry on with some of those roles, and this is what we're trying to work up at the moment, so that rather than having a kind of a discussion now where we don't know all the answers, we were looking to do all of that research, try and get as many of the answers together as possible, and then come back to committee so that you can have a more constructive discussion and hopefully reach a conclusion.
Okay, thanks for that, Dean. I'm conscious of the fact that when it comes back to the committee, we're going to have the issue again of conflicts of interest. So I'm assured by Tanya, though, that you're going to be speaking to primary care and you're going to be speaking to the LMC about this before anything comes to the committee. Is that right? Yeah.
Absolutely, yeah. We've already started engagement and conversations with the LMC and the PCNs and GP providers. Yeah.
Thank you, thank you. Paula, you've got a question.
Yeah, it was really just to say, to remind ourselves that whenever we agree contract extensions, we should always be satisfied that the services are good enough quality for us to extend them. A lot of the discussion and conversation focuses on the finances and the activity, but in awarding an extension, there has got to be that assurance that there is satisfaction. That it is of a standard that we would want to commission, because actually sometimes extending contracts does give you an opportunity to make sure you have that discussion, both with people who are using the service and those who are providing it. And I would like it to not be a missed opportunity.
Okay, thanks, Paula. Fiona, you've got a question.
Hi, yes, thanks. So it was a question about the PCN readiness, because it was interesting. I think that the West footprint are going to be ready to take it on. Now, I wasn't sure, did that mean that they actually are going to take it on, or are you going to be guiding them through it so that they're ready to go? And if so, are there any difficulties foreseen with the fact that the East don't feel that they will be ready to do that until actually the end of the current contract and starting on the 1st of April, with presumably quite a lot of other things that they are starting. So I just wondered whether that had been, was there any difficulties foreseen there?
I mean, it's something we've discussed as a team and with the providers. I don't know if Dean wants to come in here, but in terms of for West, in terms of kind of supporting the development and the readiness for delivery of this service, the practices or the PCNs over in West are working very closely with their GP Alliance, Primary Care Cheshire, who are also being supported from a project management perspective by the GP provider over in the central side of the patch, who already deliver a similar service. So there is that kind of utilisation of, and sharing of broader primary care knowledge. And also the ICP over in West are particularly interested in making this work. So when we're talking about West, we're talking historic West Cheshire CCG. This isn't inclusive of Vale Royal at the moment, but the ICP are very much supporting West Cheshire in terms of their development of this service and their readiness. But throughout the year, we're also going to be in close dialogue with the providers in the other sides of the patch. Dean, I know you've had conversations with the current providers. I don't know if there's anything you want to add there.
Yeah, we've approached all 3 providers of the current extended access scheme, and in Central and in East, the providers and the practices feel that their current model, they're happy running with that for this year until it drops into the PCN DES. So they're happy staying with the current system that they've got, which it is still used in the GP practices, so they just don't see any point in changing it until it falls into the DES. In West, the provider is CWP, and there's an opportunity to do it differently, and the PCNs within West are quite keen to take that by the horns and run with it. So I do see it as it's a good move forward. They're keen to take it on board and take ownership of it. And if we can do that, we will. All it will mean is that we'll be putting a temporary contract in place with the PCNs or with the GP Federation in West until it drops into the PCN DES. So the only risk there is making sure that whatever service we put in place for that temporary contract ideally factors in whatever's going to be in the new national spec. And at the moment, we don't know what that service specification is for next year. So the risk is we put a service in place and then we have to tweak it as it drops into the PCN DES, which will just mean a bit of extra work as we hit this time next year. So the sooner we can get the national spec for the PCN DES, the better.
Can I ask another question, Chair?
Sure.
So my comment on the first one is a comment on what we've just heard, which was more that I was interested to make sure there would be a seamless change from one group of people being in charge to another, and there wouldn't be another opportunity for stumbling. And I suppose it slightly then leads into what I wanted to check with Paula. I completely agree. We need to make sure that the services that are being commissioned and delivered are of a high quality, and sometimes they're just not needed at all. And so again, back to my previous comment about the comms team, is that sometimes there will always be some people who quite like them though. And so if we are going to be looking at changing services or even stopping some that we don't feel justify the money spent on them, we need some communications, because I know whether people will be knocking on the door to see why they're not getting the things they used to.
Okay, thanks, Fiona. I've got Gwydion now and then Leslie.
Thanks, Pam. So it builds a bit on Paula's question and Fiona's about quality. So whenever you get a large cash injection, there has to be an acceptance that I think you give the providers some flexibility to start a service, and then with time you want to make sure, I would say anyway, that you get an equivalent offer across the area. So, you know, historically, when there have been large capital injections and services like paramedics, physios have been used, the offer hasn't been the same. I'm not talking just about Cheshire, I'm talking nationally. And currently what's happening with the additional roles is that companies are springing up and offering to provide pharmacists, physios. So then you have a top slicing. And I suppose I'm asking, are we cognizant of that? And I would say that in the interest of actually providing these staff members, you'd probably accept it initially, but where does the quality control come in? Because as a practice, I'm not entirely sure, because if I have an additional roles member, my understanding is that we have them for 5 years and then we take them over, but they're not doing what I would expect that person to do. So they're not operating towards the top end of the license, and they're not giving as much value as I would expect if I was spending my partner money. And therefore, I'm just wondering, all this money that's being ploughed in, are we actually getting maximum benefit? A bit of a garbled question. Hopefully you understand what I mean. Thanks.
Does someone want to come back on that?
I can give it a go. I think you're right. I think there is definitely a quality angle that probably nationally we're missing a trick on, basically. With regards to the spend and external companies, there is a cap per role within the additional roles. So there is an upper limit, so that these companies, they couldn't overinflate the costs. So from that side, I feel more assured, but I totally agree with you. I think that from the quality side, what are these roles adding? I think part of it is a bit of a national experiment. We are looking to change how we deliver primary care, and that needs a bit of time. And I would hope that by the time we get nearer the end of this scheme in a few years, that these roles would be adding additional value in the same way as in the past. Advanced nurse practitioners are now seen as a standard role within primary care, and before that, even practice nurses. So I think there is a bit of we need to give time for these roles to develop themselves. And then hopefully, as the scheme comes to an end, that funding will fall into the global sum funding anyway, so they will continue past that date.
Okay, thanks. Leslie, you've got a question on extended hours, yeah?
It's not really a question, it's just a comment about sort of our experience as a PCN in West Cheshire. Was that really the extended hours offer from our perspective in the first place so the CWP wasn't working. We couldn't get staff to provide the clinics, and it just, often didn't exist. So we're quite keen to move forwards from a point of view of providing care for our patients and also making it work for our patch. So for some areas it'll hopefully work better, because it will be our staff that patients are familiar with and will work. So, and we are working towards getting that in place for October. So
okay, thank you everybody. So we're going to have a paper that's coming back to us on this at the next meeting. So but thank you for all of your contributions. If anybody's got anything that they think of afterwards that they need to feed in, then I'm sure Tanya won't mind getting an email in that respect, if that's all right for everybody. So can we move on to the next paper, which is the Enhanced Service Review Update. Tanya, that's you again.
Yep, sure. So again, I'm not going to hopefully go over the detail of the paper. I'm going to assume that kind of most people have read it and just bring out the key issues really. The first section of the paper sets out those kind of burning platform issues that we're working on as of now in order to find a kind of solution to deal with the issues in the kind of short term. I can provide an update on any of those specific areas if anyone's got any queries, but I wasn't going to go into the detail of those now. But what the kind of main bulk of the paper does is sets out about this time last year, we brought the schedule of the LES review to this meeting to get that up and running. But then obviously the COVID pandemic really hit and that work was deprioritised. Some of that did get done in the last financial year, particularly as I'm sure you will all remember, the care homes part of that review, and we have now got that Cheshire Care Homes Local Enhanced Service spec in place, which helps and supports and complements the national PCN DES around the same and the Enhancing Care and Care Homes framework that's been implemented nationally. What we now want to do is work to a situation where we've got those standardised specifications and equality really in funding across Cheshire for the other local enhanced service specifications. You will see within the paper there is a table that sets out which specifications are being reviewed at which time. There is phase, I think it's called phase 2 and phase 3 essentially in there. And the first phase of those specifications are already commissioned across Cheshire. However, the ask is maybe potentially slightly different across Cheshire, but in many cases the funding is definitely different across Cheshire. So they're the specifications that we want to work on first to see if we can get that right and really gain some trust from practices around this piece of work, around making sure those specifications are up to date, are asking, delivery, exactly as Paula was mentioning earlier, in a way that is, quality, improve quality for our patients, but is also being done in a way that's equitable in terms of funding across Cheshire, and getting that basic platform in place for a cross Cheshire contracts. Once those sort of phase 2 specifications are hopefully dealt with, it's then moving on to the specifications that are maybe more challenging in the sense that they're not currently commissioned in a similar way across Cheshire, and in some areas are commissioned in Cheshire, whereas they're not at all in other parts of Cheshire. So they're the second phase that we want to move into. Those first phase specifications we're working on right at the moment. We have got a task and finish group set up with other commissioners and clinical leads that are involved with those specs. And that's unfortunately where I was just before I joined this meeting, so apologies for being slightly late from that perspective. But in terms of getting their feedback and helping in terms of developing those specifications. We then have a steering group which has been set up, and the first meeting is taking place in mid-May, where we're going to talk about the progress of that first phase and how we move into that second phase. And that involves a much broader range in terms of stakeholders, from practices, from the LMC, from the CCG, from quality, BI, finance, etc. So it's a much broader range of participants really to help set that strategic direction of where we're trying to move to with these specifications, and particularly those more complex ones that I spoke about earlier. As you can see, the first phase we're hoping to get developed, negotiated and agreed, bringing back to Primary Care Commissioning Committee in Q2 of this year, and hopefully implemented for Q3. And then the more complex specifications we want to get negotiated throughout Q3 and Q4 so that they can be implemented at the beginning of Q1 in 2022. The idea of that is to make sure that that funding is secured and those outcomes are in place to be delivered across Cheshire before we move into our slightly broader ICS footprint, and working very much collaboratively with the IPC in terms of the or ICP, sorry, I always get it the wrong way around, in terms of implementation of, you know, deliverables and working towards those outcomes really across Cheshire. So it was really to give you an update that work has started again. We've got tasks and finish groups and steering groups in place. We're going to be reporting regularly through primary care ops groups, and we will be back in Q2 and Q4 with hopefully finalised specifications for you to discuss and hopefully sign off.
Okay, and again, I assume, and I know you said it, but I just want to be clear that you're going to involve primary care in that, in terms of building up those specifications, and also probably more importantly the finance teams, because I don't want to have a specification that comes to the committee and then we find we can't afford it. So yeah, that's really important, I think. Have we got any other questions? No questions? So you'd bring a report back to this committee next time?
Yep, so I'll be reporting regularly to primary care operational group of the progress of this work, so I'll certainly then keep you informed of how that develops, and then as I say, it will probably be Q2 that will bring in the kind of decision paper in terms of the new specifications for phase 2, and then Q4 for the decision papers for the phase 3 specifications.
Will you give us a range of options in terms of those papers, or will it be this is how the specification is that we've come up with? How's that going to work, Tanya?
I don't know yet. We're not that far down the line to know. We're currently in the process of comparing specifications across Cheshire, looking at potential funding models and best practice nationally. So a bit like with the care homes work, as that develops, we'll start to get a feel for, you know, is it a kind of a one solution fits all nationally in certain areas, or are there different potential options we might need to look at? I mean, one of the options that's already to spring into mind is whether we, and again, we haven't had discussions, this is just very, very early kind of thoughts, are some of these services to be commissioned as they are now to individual practices, or are some of these services, you know, to be commissioned to individual practice but with an expectation of delivery at PCN footprints? You know, there's a whole range of options that we need to look into, but we need to see what's kind of national best practice, how does that link to the outcomes we wish to achieve, and also talking to the LMC feasibility of delivery for the, you know, practices as businesses really, and with the ICP in terms of, you know, delivery throughout wider partners. You know, it might not be primary care that are always going to be delivering some of these areas. So there's a whole range of options that we need to consider before we know what we're going to be bringing back to the committee.
Okay, thanks, Tanya. Fiona, I've got Fiona and then Linda and then Neil. Fiona?
Tanya may have inadvertently answered this actually, but it's so I think that the areas that are highlighted are definitely should be community based, whoever it is that actually delivers them. But if there is a you know, the changing landscape, are we sure that they will continue to be commissioned by whoever comes next if we're putting all this effort in this year? So that was my question.
I don't think that's something I can answer, unfortunately.
Yes, we don't know, do we? But we make that assumption. Yes. Linda, did you have a point?
I just wanted to say that, yes, I just want to confirm that there are finance people involved with this and supporting Tanya. So I know that was a question to be asked.
Thank you. And Neil?
And I was just wanting to make a comment for clarity, just in terms of the final business case, as I'll call it, for this investment, that it will need to be governing body, not primary care committee, that makes the final decision, both because of the value, but also because this isn't core primary care spend that falls within the primary care budget. It's a local funding source. So I just thought it's useful to highlight that at this point, rather than have confusion down the line that why is it going there or there. But the assumption that I have, and I think that I keep advising the team with, is that this will ultimately be going through a governing body rather than a primary care committee for decision.
Yeah, I'm assuming though it'll come here first, Neil, and then it'll go to governing body.
Yeah, that's fine, but I just thought it's useful to not have people disappointed at the time when they get told it's going to a governing body.
Okay, thank you for that, Neil. That's good. Has anybody got any other questions on that paper?
No. Okay, thank you for that. We're asked to note and agree the action plan for key areas identified and note and agree the following 2 phases of work as part of this review and the next steps that have been identified. So I think we've done that. So we've just got any other business on the agenda, and I've just got 2 things which I need to raise. Has anybody got any other business? No, mine are very quick. So the first thing is there was an agenda item which we missed off the agenda and I didn't pick it up. Apologies. It was questions from the public, but we haven't had any, although we asked for them on the website. It's not that we forgot to ask. We did ask. None have come in, and so I just thought I'd let you know that. And secondly, just in terms of today's meeting, was everybody else's IT freezing or is it just mine? Do people have trouble with when people started to speak, I found it very jerky. Is that just my internet or was everybody else having some difficulty with that? Can people nod if they had difficulty? Oh, some people did and some people didn't. Okay, I've had new internet put in my house 2 days ago and I'm thinking this is supposed to be much better. But yeah, thank you very much. Okay. Our next meeting is the 22nd of July at 2 o'clock in the afternoon. That's the meeting that will be held in public. But following this meeting, we've now got a part B, which is a meeting to be held in private due to the commercially sensitive information that we're going to receive. And I'm reliably informed that if we all move on to the Microsoft Teams link on our calendars, we should be able to get into that now, even though the meeting's not due till 5 o'clock. But thank you all for attending and thank you all for the input into the papers. And I will meet again in July. I look forward to seeing you on Teams, those of you that are joining us for the second part. Thank you.